I'm really honored to be here. It feels great to be back with a lot of familiar faces. As Kester just mentioned, I trained at the University of Washington for my neurology training and for palliative care, and love to see a lot of familiar faces. And also with the Providence system, I've gotten to know a lot of people. So thank you so much for having me here and for making survivorship a part of this symposium, because it is such a crucial part of care for our brain tumor patients. And increasingly, it's been a joy to see over the last few years the increased focus to both to survivorship and also palliative care within neuro-oncology at different programs. So the objectives of my talk today are to really describe the importance of survivorship care, but I really want to provide a very practical model on what are the things we should be focusing on, because I recognize that there's a dearth of people who can do a lot of this work or have an interest in it or who are trained in it. But I think this is something that every patient who goes to a brain tumor center deserves and will benefit from. So how can we make it easier for people to integrate some things, which is what I'm trying to do in my role here at Providence St. John's and Pacific Neuroscience Institute. So what is survivorship? That definition has changed over the years. When we were thinking about cancer care more traditionally, we thought about survivorship as someone who had been through their cancer journey, finished their treatment, and now we're surviving and living cancer-free. This wasn't feasible for neuro-oncology patients who really were never going to reach a point where they were considered survivors from that definition. They were always going to wait for the next recurrence, or they were worried about when the tumor would come back. And so now there's a newer definition of survivorship from the NCI, which really fits our patients also, which considers the survivor from the time of diagnosis through the balance of their life. And it also makes room for their family members, friends, and caregivers. Like often wives will tell me, or husbands will tell me, I feel like a survivor in this too, in a different way. And this definition allows for that, so that everyone who's involved in this really tumultuous and painful process is a survivor of it. And they're going through really intense phases, through a very intense disease process, which is different than what we see in a lot of other cancer journeys, which I'll touch on just a minute, how it's different. But this definition also allows you to separate from the disease, which would be, in our cases, glioma, leptomeningeal disease, brain mets. And we're thinking about all the treatments that we could do. We could do chemotherapy, IV therapy, visits to the hospital, injections, CAR T therapy. And maybe we'll do that and we will not get a response, but that doesn't mean that the patient isn't a survivor, because when we look at this new definition, we're really looking at the patient experience and how they are affected by their community, how they have a social system, how they're physically reacting to treatment and suffering through treatment or doing well through treatment. And several speakers today touched on the toxicity aspect of treatment and how they're cognitively impacted by their process. So it's really a patient-centered look versus a disease-centered look. And a neuro-oncology journey, increasingly, I describe this as a roller coaster. And as patients go through their phases, they're like, you're very right, Dr. Sharma, like it really, in the beginning, it already feels like too much, and then you're coming down again and you're going up again, and it's life-changing. It's most often lethal. It impacts every aspect of life, from how you're thinking, how you're functioning, how you're working with your family, how you're going to work. There's a very high symptom burden, as we're all aware, which also leads to high distress for patients and their loved ones. And there's a very high rate of dependence. Some studies have found that 80% of patients with brain tumors are never able to go back to work, which is much higher than other cancer populations. This leads to profound caregiver burden. We're also looking at things like seizures resulting in inability to drive. Depending on which state you are, it could be as long as a year, which is not insignificant, especially when there's no good public transport. So there's a lot of different aspects to the neuro-oncology journey. And most of all, it's the fact that their personality changes, their cognition changes, they become different people through the course of this journey, which may not be an easy process. And so a few months ago, the brain tumor social media, which is a hashtag that was started by a patient survivor, they bring together patients, clinicians, caregivers in an online chat every month. And it's a really lovely place, and there's so many active advocates who are living with brain tumors, and I really like hearing their journeys on Twitter. But this was a question about survivorship, and Charlie Blotner, who's a social worker who works with cancer patients, but also is a brain tumor survivor, describes it as anyone who wakes up the day after the initial diagnosis is a survivor in my mind. I think just being alive is what I consider surviving these days. But the difference between brain tumor survival and other cancers, I'd say, is that you have to continue planning for the big decline, the cognitive deficits, the mobility, the vision issues, the issues when they start to interfere with activities of daily living, where I know that I can't do things or won't be able to do things. I need contingency planning for that. And another patient who has a grade 3, and she shares about that, discussed that before I was diagnosed with brain tumor, before prognosis, I assumed survivor meant cured or all better. But now I've learned that survivorship means that I'm still alive, and it helps me to deal with the uncertainty. So really, this definition has helped our patients feel more part of that survivorship place, where their focus is on continuing to live their best life versus focusing on, okay, my treatment will be done and then I'll live my best life, which can really be harmful and not something that's going to be real. But the other important thing is that needs for patients with brain tumors will change throughout the journey. So while we're still focusing on the patient and not the actual disease process and the treatment, we do need to recognize that with brain tumors, there is a certain cadence to their journey. There's an up and down. And this was a beautiful model from Jennifer Phillips, who is a palliative care specialist in Australia, who wrote this paper 4 years ago now, where she focused on these different transitions in high-grade glioma. And I think they can also fit a lot to other conditions like leptomeningeal disease. Thankfully for brain mets, we're having longer periods of black plateauing now, longer periods where they're stable. But with the high-grade glioma, you're really starting from diagnosis, you're getting radiotherapy, and you might feel okay. Then you have a recurrence, then you deteriorate again, and then you're eventually talking about death. Now, the timeline may change dramatically depending on your markers, how you respond to treatment, but we need to be aware of the fact that needs in the beginning are different than needs in the middle and needs in the end. And our care and our services should be aligned with those needs. And the only way we're going to be aligned is if we learn about them, which has only really started happening in the last 15, 20 years, and continuously monitoring their needs. So hearing about it, which is where a lot of work with patient-reported outcomes starts to come up. And we have to be proactive in gathering this information and making sure that we are supporting them, because universally the data shows that caregivers at least want more information, want to be asked more often how they're doing, and would like to have services that they can trust and rely on when suddenly something changes, when their loved one deteriorates. And so to provide high quality survivorship care, we need to focus on different aspects of decline in these patients, including the physical, the cognitive, the emotional, the social changes, and also concerns about the financial aspects of brain tumor care in the future. And I'll touch briefly on some of the big highlights in each of these, just to emphasize to you what we really are the biggest concerns from the literature so far. So of course, we are more familiar with disease and treatment-related side effects. We all deal with this with radiation, with chemotherapy. We deal with fatigue, nausea, appetite changes. A lot of our patients are on steroids. We're looking at steroid toxicity, side effects of medications such as Keppra. And so there's a whole variety that we need to be able to follow, and not everyone is going to have all of these symptoms, but anticipating them, making sure that we address them will help them get through treatment more successfully. And if they can get through early treatment more successfully, then as we get later on, when symptoms are increasing, stamina is decreasing, and fragility is increasing, we can have created a model for success, and they'll have known what works for them for certain things. So I often suggest making sure that at every visit we're going through a checklist. We're checking in on patients as they're going through radiation, either mid-radiation, at the end of radiation is usually most practiced. But for some high-risk patients, even checking in every 2 weeks, or having a nurse check in every 2 weeks to make sure we're staying on top of these symptoms. And then from a cognitive and emotional perspective, this is a huge area, and an area where there's a complete lack of evidence. We've extrapolated everything we know on emotional management from general depression and from other conditions, but we have not really done studies in brain tumor patients. And there was a recent Cochrane review that was updated in 2021, which found once again that there are no evidence for any of the medications that we use. And they are toxic in these patients. Almost all the antidepressants have risk of seizure, although bupropion is most well known for it. A lot of them will interact with other medications. And yes, there's a lot of excitement about data in terms of fluoxetine and how it might help, but then should everyone be on fluoxetine? Like, we really don't know those answers. And apart from depression and anxiety, which is very common and understood as part of the adjustment disorder, patients who have frontal lobe disease can have really significant irritability. They can have lack of insight and judgment and awareness, significant disinhibition, which is quite heavy for caregivers. The social aspect I've discussed, so I won't go into for lack of time, but we're looking at patients who become very dependent and lonely. And then one other aspect that isn't really covered is how expensive the care is. Having a brain tumor in America is not for the poor. Even though we like to think that we're providing care, most centers that treat county patients or patients with low or poor insurance don't have the same trials that richer centers do, or academic centers do, or centers that don't take a lot of insurances do. So there's very high treatment costs just from that, and patients sometimes pay out of pocket to travel to trials. But also a majority of patients, as I mentioned, are unable to work. Their caregivers sometimes have to stay home. And we are not considering the other burden of care, which is parking, going to appointments, traveling. And later in life, almost 100% of our patients will need a caregiver to help at home because they become so dependent from a physical perspective. And in America, that is not covered by insurance, and most caregivers are $25 to $26 an hour in most major cities. So, and then lastly, we're looking at future goals, like how are we talking about who they want to make decisions for them? If they're doing well, are we talking about returning to work or thinking about alternative careers? Are we helping them with legacy building, or are we helping them with their children and how they're talking to their children and helping them cope? So obviously there's many areas that we need to focus on with patients. And a key part of having survivorship care is high quality communication between the patient, the caregiver, and the clinician. So all of these areas start with being able to ask the questions, being able to talk to patients in an empathetic way, and being able to get the answers. And then, as I mentioned, once we get the answers, following them on an ongoing basis. So really a good patient-reported outcome method that allows us to manage symptoms and follow them. And then lastly, addressing them. And that's where we get into research that needs to be done to address a lot of these symptoms, which is still has not been a priority in brain tumor care. And so all of this requires integration of palliative care principles, and all of that can lead to high quality survivorship care with these pillars. And what are palliative care principles? I also wanted to mention the timing is important, that we want to have the right conversation at the right time. Otherwise, we'll lose the rapport with the patient. If we're talking about advanced directives right when they're diagnosed, they might get scared, they might get pessimistic, they might feel this is not the doctor for me. So we also want to time it at the right time. And palliative care is the art of alleviating suffering, is what the definition that I like, and the pursuit of quality of life. So it is not hospice, it is not end of life, it is really improving life for patients, and all of us could do with some palliative care. And what we find is that when we integrate palliative care into any type of chronic illness, so serious illness care, we improve quality of life, and we improve patient symptom burden, we improve caregiver quality of life. And so I want to end the last few minutes by discussing some models of survivorship that exist out there. So this is from UCSF. They had a wonderful donor who was a patient who's lived with brain cancer for a long time, who helped them start this program that the goal is to enhance the wellness and quality of life of patients. And they did a wonderful presentation at SNO this year. It's really a multidisciplinary, very thoughtful program that was developed based on patient feedback and focus groups. And based on their feedback, they found these areas which I've touched on, that patients want cognitive support, they want more wellness opportunities, health education, and they want to connect to each other. And lastly, they want to have meaning and purpose, which is built into the program. And so in each of these areas, they've started either a support group, education sessions they have a cognitive care clinic where they have neuropsychologists. There is a nutrition integrative medicine course that patients can do. There's a peer support program where the volunteers are trained and they reach out to other newly diagnosed patients. For the connection aspect, there's a monthly webinar series. So a lot of small things have been brought together to create this larger program that meets different needs for different patients. Now, obviously this requires a lot of funding and resources. When I started at Providence St. John's PNI, I had no funding and resources, but I really wanted to start a survivorship program. And we did have a wonderful survivorship nurse practitioner who worked with the oncology service. And so we developed what we call the Comprehensive and Supportive Care Clinic, which was started in last February, so about a year. And it's me and a nurse, and we have administrative assistants. So it's a very small group right now. But even with that, we've been able to slowly develop our panel of patients. We focus on symptom management from an early point. So we try to get patients who are starting treatment so we can establish rapport with them, because I find that if I can demonstrate to them the benefit of having my involvement early on, they will continue to have conversations with me, especially when the time gets tough. In the beginning visits, we just focus on radiation side effects, symptoms, nausea, constipation, which is a huge problem with some of the drugs we use. And then as we get to know each other better, we talk about goals of care. What does a good quality of life mean to you? Who makes your decisions? So it gives us time, especially with these high-grade glioma patients, to be able to have these conversations before things start to decline, and especially before cognitive impairment starts to set in. And then we also focus on diet and supplement education. We will provide counseling, but most importantly, I feel a big job of what we do is just connecting people to resources in the area, good therapists, good physical therapists, good family counseling, making sure that their children are supported. So kind of really providing a holistic view of not just the patient, but also the caregiver and the family that's going through the journey. And so far, it's been very well received. Patients haven't been scared of being referred to our clinic. I also practice neuro-onc, but this is something I do 1 day a week, and I find it extremely fulfilling. But as we are growing, we're trying to also add more to this. So that my next step is going to be adding a regular support group, especially for our young patients who are going through the same journey, but harder because they don't have the funds yet. They don't have a retirement. They don't have children. They don't have a lot of the community we look for when we're older that helps guide us through serious illness. We're also starting an education series. We're hoping to do a peer support program for caregivers. And we are hoping to get a social worker into our program. So this is sort of starting from zero and going up by adding just even a small amount of time every week dedicated to our highest risk patients. And one of the other things that's helped is that it's taken away time from our general neuro-oncology clinic where they would have focused on symptoms or they would have had to talk about goals of care. Often we can take that time to just move on to the next patient, which we have to do sometimes in a busy clinic, because we know that some of these conversations are happening in a separate time where I'm giving them plenty of time. I also do this clinic virtually, which is something that my prior research showed that patients really don't want to come to another physical appointment with brain tumors. And so we do a lot of virtual care here so that they have accessibility to us. And then I want to end with highlighting to you a patient survivorship plan that was developed by Dr. Leeper and colleagues that is available at the SNO website, which is a great way to look at, to give to the patient for them to develop their own plan, but also to kind of think about all the areas of creating a survivorship. So with that, I'll end, and I encourage all of you in your practices to consider how to bring more survivorship care to your patients, because I guarantee you that they want it and they need it, and they will love you for it. Thank you.